Hello, good morning, ladies and gentlemen. Welcome back. See some familiar faces, new faces, smiling faces. That's great. Thank you very much for your precious time that you're spending here with us at the Speaker's Corner at the IDS 2025. And it's 11 o'clock and time for the next presentation. It's followed also by a panel discussion. So this is unique. This is really nice that we have that. And you will learn about a new type of dental varnish from VOCO that combines BioMin glass with a proven Profluorid Varnish. So find out how this innovation can also make your daily work easier. And I think that is one of the most important things in the daily business. So for the first part, please welcome dentist and research assistant at Queen Mary University, Emily Sara Thambi, with a big round of applause. Thank you for staying here. And for the panel, we will then have on stage Dr. Maya Ayub. She's already waiting here in the first row from Lebanon, and Dr. Matthias Mehring. He was also here yesterday from Knowledge Communication and from VOCO. So we wish you a lot of nice insights. Thank you very much.
In dentistry, the main priority has always been restorative care. Even today, most of the products that you look around in this exhibition have to do with restoration. It's mainly designed to repair damage, to fill cavities, to rebuild enamel, and restore function. And that makes sense, right? Because most of our patients come to us when they have an active problem. But what if we could shift that focus? What if instead of waiting for damage to occur, we could actively protect the enamel and strengthen tooth before the damage can happen? And that's where preventative dentistry comes in, or prophylaxis. And today, I'm excited to share my research on a novel dental varnish developed at VOCO. Good morning, everyone. I'm Emily. I'm a research associate at Queen Mary University of London, where I've been studying about this novel varnish, how it interacts with the enamel, and how it effectively prevents mineral loss. In the next couple of minutes, I'll take you through the science behind this innovation, the research that supports it, and why shifting our focus to prevention could change the future of dentistry. Let's start with the basics. Everyone knows this is a picture of a tooth. The main concern here is the outermost layer, which is the enamel. It's the hardest substance in the body. Everyone knows that. But what does the enamel actually consist of? 97% of the enamel consists of hydroxyapatite. It's a mineral that's found in teeth and in bones. And that's what makes it so strong. So it's chemically stable and it's got good structure. And that's what hydroxyapatite looks like. The critical pH here is greater than or equal to 5.5. And what does that mean? So at 5.5 and above, hydroxyapatite is stable, so it remains intact. As soon as it becomes exposed to an acidic environment, that's when it demineralizes or it loses its ions, and so it breaks down, and then you have caries in a clinical scenario. So if I want to protect my enamel, or if I want to protect teeth, I would want to have a mineral that is stronger and more acid-resistant than hydroxyapatite. And that's where fluoride comes in. And you have fluoride in your toothpaste and all your daily oral hygiene products, like mouthwashes, etc. When it interacts with fluoride, that's when you form fluorapatite, which is chemically even more stable than hydroxyapatite. And if you see, the critical pH here is 4.5, which is almost 1 unit less than hydroxyapatite. So basically what it means is fluorapatite is more acid-resistant than hydroxyapatite. And the whole point of using fluoridated products is so that you form an acid-resistant layer on the outer surface. This is just a diagrammatic explanation of what really happens in the oral cavity. I've kept it light. I've thrown in some cartoons because scientific data looks a bit boring with all the graphs. What I'm trying to explain here is whenever you eat your food or anything happens, you've got a lot of bacteria growing, a lot of karyogenic bacteria. The bacteria sort of secretes an acid, and when that sits on the tooth for a long time, that's when demineralization happens, and then you start forming cavities. When you have a good source of calcium and phosphate ions from the saliva, which is naturally available, plus when you use fluoridated products, so here it's a toothpaste, you could use varnishes, anything like that, When calcium, phosphate, and fluoride combine together, that's when fluorapatite is formed, which is the acid-resistant layer that I spoke about. Demineralization process, so you start here with the healthy enamel. Everything is fine. You've got balanced dental plaque. When demineralization process starts, you first start with a white spot lesion. What is a white spot lesion? It's basically an intact surface, and you have a chalky white appearance. It's very hard to identify, but if intervened at that stage with topical fluoride application like varnishes, you can reverse the process and get it back to healthy enamel. But if not intervened at that stage, it further progresses, and that's when you start having dental caries and dental cavities. So this stage is irreversible from the white spot to the dental caries, and over here, you can reverse it by remineralizing it. And that's why intervention at this stage is very, very important, because restorative care is more expensive, more invasive, more painful. So patient education about all these stages is very important, so patients know at what stage to intervene and get topical fluoride applications. These are typical indications for varnish application where you have white spot lesions. So it's an intact surface with a chalky white appearance. Gingival recession where people have sensitivity because of receding gums. You have exposed dentinal tubules, and also enamel wear caused by attrition. So all of these cases, you can use dental varnishes. This is what white spot lesions look like. I'm not sure if it's clear, but at that stage, the last one, white spot lesion with a cavitation, that's where you have to go for restorative care. So all the other cases, you apply topical fluoride. Post-orthodontic treatment, you get these chalky white appearances around the brackets. So during treatment, applying fluoride varnishes also really help. This is pediatric cases where you have molar incisor hypomineralization, where you have like really underdeveloped, enamel at the molars, and that is more susceptible to dental caries. And so having this fluoride protective effect really helps. So what's the overview? Topically applied fluoride varnishes have been used extensively as preventative or minimal intervention for dental caries. A goal of minimally invasive dentistry is to manage non-cavitated caries lesion non-invasively through remineralization. Hence, you need to have calcium, phosphate, and fluoride that is bioavailable. So it's free, and you can combine them to form apatite. There are two generations of varnishes. You have the first generation, which is the standard sodium fluoride varnish, and the second generation, which has got an additional source of calcium and phosphate. Some of them are also available, which is the Durafat and the Profluorid Varnish. These are just some pictures of the varnishes available in the market. Standard sodium fluoride 5%, and the ones above have an additional source of calcium and phosphate. These are some ADA and WHO recommendations where they think the American Dental Association says it's effective in preventing caries in primary and permanent dentition for children and adolescents. So fluoride varnishes actually work. World Health Organization says, in comparison with other modern fluoridation measures like APF gels, fluoride varnishes are advantageous for caries prevention, and their increased use is recommended. So how can existing varnishes be improved, and what makes our solution better? I've thrown in a picture of Dexter because he's one of my favorite cartoons, and he's also a scientist. Over here, we incorporate BioMin, which is a bioactive glass targeted for calcium and phosphate release. What I want to emphasize here is it's a controlled calcium and phosphate release. So the BioMin glass differs from the original 45S5 bioglass, which was developed by Larry Hench by including fluoride into its composition. 45S5 bioglass is used in toothpaste like Sensodyne, so that's what it is. And this is what it looks like, and you're adding fluoride into it. The BioMin glass is included in toothpaste for enhanced enamel remineralization and long-lasting protection. So there's a lot of clinical data that is available. It releases calcium, fluoride, and phosphate over a 12-hour period. And what I want to highlight here is a slow and prolonged release. You don't want to be having a burst release. What happens is when the material is in the saliva, as soon as it releases all these therapeutic ions, it can easily get washed off because of salivary clearance. What you need is a slowly degrading glass or material that would constantly release these therapeutic ions. dissolves more effectively in acidic environments, providing optimal protection. So bioactive glasses tend to dissolve even faster in an acidic environment, which is great, because dental caries is usually formed in an acidic environment, and that's where you need all these therapeutic ions to be released. The science behind the varnish, what is in it, and how does it differ from other varnishes? So that's the BioMin glass, and you have calcium, phosphate, fluoride, and silica in it. It's a fluorocalcium phosphate phosphosilicate glass, and then you have your 5% sodium fluoride, which is in the varnish. So what happens is, the glass breaks down in the saliva to release these therapeutic ions. What we're mainly concerned is calcium and phosphate release. These ions precipitate and form an acid-resistant layer outside the enamel, and that's what it forms, fluorapatite on the surface. This is what the new varnish looks like with the BioMin glass in it. This is the packaging, and it looks great, but we're more interested in what the material actually does. And does it really release all this calcium, phosphate, and fluoride? And that's what we're going to look at in the research. So my main objectives were to analyze their ability to form fluorapatite or calcium fluoride, and to investigate their ion release. So I want to see if the material is actually able to release these ions. This is a brief description of what I did in my methodology. I've compared the BioMin varnish, VPV plus BioMin, with the GC-MI with Recaldent. And what I did was I coated an equal amount of the varnish that you would generally apply on the tooth, measured them, coated them in glass cover slips, and then immersed them in artificial saliva of different pH, so acidic pH and basic pH. What I did then later is I took the solutions and I measured them for fluoride, calcium, and phosphate, and the cover slips that were remaining, I analyzed them to see if there was actual apatite formation on the cover slip. Results for the material characterization. This is the 19F mass NMR spectroscopy, and what it basically means is it's able to identify any trace elements in your material. So remember the cover slips that I told you about where I immersed them in artificial saliva. I want to see if there's apatite. So what the 19F is going to do is it's going to give me a chemical shift for apatite. Over here, you see a chemical shift for sodium fluoride, which is -224. What I'm concerned about is this red circled chemical shift. And -107 is actually very close to calcium fluoride. So it's not apatite yet. And if you see in the GC-MI, you can have a huge peak there at -107, which means there's more of calcium fluoride formation there. But if I want to confirm if it's apatite or not, I need to check if you're getting a signal for the phosphate, which is in the apatite. So I do the 31 phosphorus NMR, which is highly sensitive, and it can detect. And that's what we get. We get a chemical shift for apatite here with the VPV plus BioMin varnish, which is at 3.5, and the chemical shift for apatite is generally around 3 ppm. So here you can confirm that you're actually forming fluorapatite with the varnish. However, with the case of GC-MI varnish, you don't get any apatite formation. It's just a no signal there. And what I want to reiterate here is, you did see a large peak here for calcium fluoride. What happens is, if a material is driving towards calcium fluoride formation, it takes up the essential calcium and the fluoride ions, which are necessary for apatite formation. So I would rather drive it to form apatite over calcium fluoride formation. Apatite over apatite tends to nucleate faster than different crystals, if that makes sense. We did some fluoride ion release data, and you can see a significantly higher release with the MI varnish. But you don't see apatite formation. And that's what I want to say, is that more fluoride doesn't necessarily mean more apatite formation. Going back to the first few slides, you need a slow, consistent release of calcium, phosphate, and fluoride to create apatite. I measured the calcium and phosphate release from the materials, and over here you can see that the calcium and the phosphate for the VPV plus BioMin actually goes into negative. So what this means is the material is able to take up the ions from the saliva, from the artificial saliva, and utilize it, and that's why you see it going into negative. Whereas in the case of the GC-MI varnish, you see a very low release, and obviously with the NMR, you'd see that there was no apatite formation. Unveiling a groundbreaking scientific approach to X-ray microtomography to analyze the effect of the varnish. So what is X-ray microtomography? Is basically scans were taken of the sample over there, And then you get these scans that were taken every 2 hours over a period of 5 days. And what I did is, 2 days, I acid challenged the tooth, so to create a surface lesion, sort of close to a white spot lesion. And then I treated it with the VPV BioMin varnish, re-immersed it into acid later for 2 days, just to see the protective effect of the varnish. The protocol, like I said earlier, a sound premolar was taken, a window was created 4 by 4, and then the first 2 days, you had an acid challenge over there at a pH of 4.5. The varnish application was done, re-immersed in artificial saliva of neutral pH for 24 hours, mimicking the clinical scenario, because varnishes don't tend to stay longer than 24 hours. And then we remove the varnish just to see if there's been any effect, and then re-immersed it into acidic solution to see if there's any protective effect of the varnish. And now the results for the X-ray micro-tomography. I'm going to show you a video. I'm going to keep it playing for a couple of seconds. If you can see any difference between the left and the right-hand side. The highlighted area there, if you can look closely, it continues to move over with respect to the other side. So this side is more static, and that one, you can see a slight difference of the lesion moving, progressing further. And what is really happening is that after 5 days, this is what the tooth looked like. So this side is where we had the varnish protection, and the other side, we did treat it with varnish, but we removed it post 24 hours. Ideally, if there was no varnish protection, the enamel would have demineralized even further. But we want to quantify this. Just looking at pictures doesn't really give us a clear picture. So we compared the data of demineralization before treatment and demineralization after treatment. So demineralization without the varnish coating for this area is what I'm going to show you. Line profiles are basically drawn on a 2D plane just to see the variation of mineral concentration through that side. So literally, it's this picture, but in a 2D form. And we're going to analyze the mineral concentration that's happening through that line profile. And this is the graph that we get. So the line profile starts from the outside, so there's no mineral there, so it's at 0. As soon as it hits the enamel, it shoots up, so that's sound enamel. And when it goes into the dentine, because dentine has less mineral, it goes down. I want you to focus on this area here. This is the starting point, the green. And then after 1 day, it demineralizes. 2 days, further demineralization. And you can see the lesion moving towards the dentine. The yellow line and the gray line, you can't see the gray because it's overlapping, is where the treatment was done. So there was no demineralization there. And then after treatment, you still see it progressing. But if you look at it, you can see that there's some difference between the first 2 days and the next few days after treatment. This is how it looks like if you elongate the graph. So before treatment, the demineralization was much more aggressive. After treatment, that area is significantly reduced. So you can see some protective effect of the varnish, although the resin layer was removed. We also calculated the mineral concentration variation for the side that had the varnish on, just to see what kind of protective effect you're getting from the rosin resin layer as well. Did the line profile again for that, and this is what we get. If I elongate it, so you had demineralization in the first half, but after treatment, it doesn't progress further. So what I'm trying to highlight here is in a clinical scenario, even if the varnish is left on for some time, it has a protective effect, like a protective barrier on the enamel, preventing it from further demineralization. And this is where patient education comes into hold, where you have to educate patients that after applying a varnish, you're not supposed to eat. A lot of people get fussy about that, and then they just continue to do what they want. But data like this can actually help them understand as to how important it is to follow the rules and then just to kind of get the optimal effect of the varnish in your mouth. We did some Vickers hardness testing with some pH cycling just to mimic the oral environment to see if the varnish is able to increase the enamel hardness. And this is what we got. So I tested the varnish with these 3 other groups. Control was standard toothpaste, nothing else. Had a slight amount of increase with the hardness. But the main concern is here with the 3M ClinPro White and the GCMI. You do see some increase in hardness, but with the VPV plus BioMin, it's significantly higher in that group. So it does strengthen enamel, inhibit demineralization, and also significantly hardens the enamel. We did some scanning electron microscopy to see if it occludes dentinal tubules. Because I earlier said one of the indications for dental varnishes is for people who have gingival recession or exposed dentine. These are my samples. So this was the control, no treatment. You see exposed dentinal tubules. There's nothing occluding. It's nice and open. So in this kind of dentine, in a clinical scenario, the patient would be undergoing a lot of dentine hypersensitivity. And to prevent dentine hypersensitivity, you need to sort of have a material that's going to occlude or sort of give a blanket covering over these exposed tubules. And I treated one half of the sample, left this untreated, and treated this part. And you can see sort of a blanket cover over these exposed dentinal tubules. But what I want to really know is, if I remove that rosin resin layer, does the varnish still have an effect? Has it been able to form some sort of apatite? And that's what you see here. After 24 hours, I did remove the resin layer. And this is the before picture where you see all of it is exposed. Post-treatment, after 24 hours and some pH cycling, you see some of it is occluded completely. Some of them are left partially occluded. But it's a significant reduction in exposed dentinal tubules. And this can be really helpful for people undergoing dentine hypersensitivity. Conclusions. The new VPV plus BioMin varnish significantly increases hardness compared to other treatment groups like we saw. The GC-MI varnish released about 90% of sodium fluoride in 24 hours. However, no evidence of apatite formation. And like I said earlier, we need to have the bioavailability of calcium, phosphate, and fluoride to form apatite rather than calcium fluoride formation. And more fluoride doesn't necessarily mean apatite formation. You tend to drive it towards calcium fluoride because calcium fluoride's got 2 fluoride ions in it. The new VPV plus BioMin varnish is able to inhibit demineralization in acidic environments. And that's what I proved with the whole XMT studies, where we coated one half and the other half was left exposed. And you do see a significant reduction or inhibition in demineralization. Acknowledgements. I'd like to thank everyone at Queen Mary University and also at VOCO for giving me this opportunity to conduct the research and present my data. And now we'll have a panel discussion with Dr. Matthias from VOCO and Dr. Maya. Thank you. Do you want me to?
Yeah, Emily, thank you very much.
You're welcome.
For the interesting presentation of the results. You did kind of big study, so we have seen all the technical aspects now, what the reason is behind that varnish. So thank you very much for presenting this. I would like to start this discussion before we jump over to some questions maybe from the audience, is to also shed a light on the clinical side of that. So Dr. Maya from Lebanon, she's a dentist, mainly interested in pediatric dentistry. Is very familiar with the use of the fluoride varnish itself. But what do you think now, if we now have included this bioactive glass with this proven results? So how could this improve your daily workflow, or what are your overall thoughts on this?
You know, as a pediatric dentist, we work on prevention mainly, not in treatment, in prevention. So when improving the VPV with bioactive glass with BioMin, so it's a big improvement for us. It enhances remineralization, it decreases demineralization, it reduces hypersensitivity. So it's a very good combination. So it will be a very good combination. So it enhances remineralization, as you said, by forming a like layer hydroxyapatite. With the fluoride, yes, it will become a fluoroapatite. So it's the enamel. It enhances the whole tooth.
Exactly.
Chemically.
Yes.
Yes.
So yeah, that's what we have seen in the slides. Maybe, Emily, the bioactive glass in there, so the BioMin, so you have shown it, but maybe for the audience you can just summarize it quite quickly. So what is it doing actually, in addition to the fluoride which is in there? So what is the benefit of having this there?
So with the standard sodium fluoride varnishes, you only get a source of fluoride, and you get a huge source of fluoride, which is great. And there's a lot of clinical data proving that standard sodium fluoride varnishes work. The whole point of adding a bioactive glass as a source of calcium and phosphate is it's got a controlled release. So other sources of calcium and phosphate in other varnishes have a burst release. So as soon as they come in contact with saliva, they tend to release the essential ions. With bioactive glasses, it's pH indicative. So when it gets more acidic, more choriogenic environment, it releases more. So it doesn't all of a sudden come in contact with saliva and release all the essential ions. But when it's needed, that's when you have a slow, sustained, and prolonged release of calcium and phosphate. And I think that's what gives it an edge over the existing varnishes in the market.
So it neutralizes acids.
Yes.
And the fluoride,
well, yeah.
and the fluoride inhibits the metabolism of bacteria. So combined,
It's going to be great. Yeah.
Yes.
Okay, so to sum it up, we clearly see a benefit. We have a formation of a crystalline layer on top,
Yes.
which seems to be something like fluoroapatite, which really helps as we have seen. Okay, yeah, thank you. Maybe there is any question from the audience here that we would like to discuss. Yeah, over there. So I think you'll get a microphone.
Hi, I am Dr. Nina from Macedonia. I am working as orthodontist and my clinic is treating a lot of kids. So we have a lot of experience with varnishes.
Yeah.
What is your recommendation? How often and what age we can start with the treatment?
Do you want to? Well, it really depends on how the caries assessment is. So when you do a risk assessment, if they're more prone to caries, you would be more frequent with the fluoride application. Generally, for normal, healthy people, it's considered once or twice in a year. But I think with children,
High risk.
yeah. Sorry?
High risk.
Every 3
High risk,
months.
yeah, every 3 months. And
Same as the VPV, regular VPV, so we can use it every 3 months. As you know, the adolescents, they don't like to brush their teeth, they don't like hygiene, they don't like to take showers. So mainly with orthodontic treatment, so we don't have the white spots after when we remove the braces. We would love to put it every 3 months.
Okay, thank you. We were recommending every 4 months, but this is something. Okay, thank you.
There was also a second question from you, which was the age. Is that right?
The age. So for orthodontic treatment, it's like 10, 12 years old. So of course you can put it. We can, as pediatric dentists, we begin to put fluoride varnishes at 3 years old.
So in general, what all manufacturers are recommending is as long as the patients can control their swallowing reflex. So that's the main reason. But of course, you have to look from case to case. 3 is a good guess. It really depends at the end on the patients. So.
And is it safe to use, let's say, for 1.5 years when they bring us with the already white spots? So
ECC, early childhood caries. Of course, the VPV is already sticky. It doesn't get swallowed easily by saliva. It doesn't get, with the suction, it can't be removed easily with the suction. So it's sticky. Of course, we can use it.
And does color change when you apply? Is it yellowish
No.
with the saliva? Does it change when the saliva comes into a contact?
No, it's transparent. It's sticky,
Transparent.
although, but
Sticky,
yes,
but
it's sticky.
transparent.
Yes.
Okay.
They will tell you we have something on our mouth. It's sticky,
Yes.
but it's okay.
Can they feel roughness of the surface?
Yes.
Yes.
Yes. So that's normal because there is something on top. It must be. You must feel something. It's
Okay.
not smooth
We will
because
try
we have
your products when
this
they...
kind of stickiness which is required.
Thank
So that's
you.
why they definitely feel it. And the shade is transparent, or at the end it's tooth colored, so you don't see this on the teeth, which is also a criteria. Are there maybe other questions from the audience? If that's not the case, I would like to go on. We can just pick up that question a little bit. We talked about the frequency of application. We said every 3 months. You said every 4 months, which is totally fine, depending on the growth or on the lesion. But what about how long does it stay on the tooth? That's also a question which comes up quite often. So once you applied it, so what is your information about that, or what can you say about that? And maybe as a follow-up on this question, so what happens if it is gone or when it is gone after a certain while? Emily?
I think it also depends on patient compliance to what kind of rules you tell your patients. You know, we advise patients after fluoride varnish application not to eat or drink anything acidic or have anything hard for the next 4 hours. But it really depends on if the patient's actually going to follow that or stick to the rules. And ideally, it's supposed to be staying for 12 hours, but it could stay for 24 hours, not in the smooth surface areas, but proximally in the contact points. And that's essentially where you need the fluoride because that's more prone to caries. And then the second question you asked is, if it goes, does it still have an effect? And that's what I showed with the XMT data, where I did treat it with varnish, and then I removed it. And you still see a significant reduction in demineralization, even if you lose the resin layer. So whether it's there or not there, it does have an effect.
So we advise the patients not to brush their teeth.
Yeah.
For 24 hours or for 12 hours, and not to eat chewy food.
Yeah.
So it will help.
It stays longer.
Yes.
But even if it doesn't, worst case scenario, you still see an effect with the varnish.
So I think you have shown it in your data. So you recorded it not only for 12 hours or 24 hours, but for several days.
Yes.
And there is a long-term effect. And of course, more often you apply that material, the higher is the effect, of course. So I would like to get back. We touched this a little bit already. But what about the active glass, actually? So how does it help in special things like white spots lesions, or if we're talking peridentic dentists, what about MIH, which is a very common issue nowadays?
You know, for MIH, okay, we treat the molars, but for the incisors, we go for minimal invasive treatments, especially for kids under 16 years old. So for the white spots or brown spots, the brown spots, so it works.
Yes.
It will work.
Also helps with the sensitivity, I guess,
of course,
for the patients, because they're more prone to caries. And having a varnish like that, definitely with the SEM results, you can see the occlusion of dentinal tubules, helps in hardening the enamel as well, which you had the data there. That would help with MIH patients.
And it will seal the micro cracks, so it's double effect, closing the microtubules in the dentine and sealing the micro cracks, so it will reduce hypersensitivity.
A common topic is also when it comes to fluoride varnishes or any product which contains fluorides. So what about any bonding to the teeth? If we maybe talk about orthodontic brackets, so we want to bond them to the teeth. Do you have any idea or information how this would work? Is there any issue maybe, or what do you think about that? Because you have shown you closed the dentinal tubules, which we basically need to get any kind of adhesion.
It doesn't affect adhesion there because you're just forming mineral. But I think there is another varnish which has resin infiltration. There, it actually blocks the pathway. But for this one, you're just forming like a surface layer of acid-resistant mineral. So that doesn't affect with your bonding adhesion or anything like that. If anything, it only helps in remineralization.
Okay, yeah, very clear. Thank you for that. Fluoride varnishes, do you see any alternatives to this? So you've shown we know there is the huge market of fluoride varnishes. Now there is an improvement with the BioMin, bioactive glass. So in general, do you see any alternative to fluorides, or is that the technology and the strategy we should go also in the future? So what is the actual or current market situation?
Well, I mean, fluoride's doing great. There are other alternatives to fluoride as well. It really depends on which country it is in. Like, some places, they're not very keen on using fluoride. And so you can use chloride even. You form chlorapatite. There's BioMin C, which is a different version that doesn't contain fluoride. But there's nothing that does as well as having fluoride in your products, because you essentially form chlorapatite, which is way more acid-resistant than your naturally occurring mineral. That is hydroxyapatite.
So we have many alternatives,
you do have,
but nothing can take the place of the fluoride. This is it.
Exactly, yeah.
Okay. So, are there any other questions from the audience? Maybe? Okay, that's not the case. First of all, I would like to sum up once again. Like to thank you both for coming here and supporting VOCO with that material. So what we have here is kind of a novel varnish. That's what we also had in the title here, which is a next step in, let's say, hardening the enamel or strengthening the enamel. It's a new approach, but what we have learned from, especially from your research, is that it's not only the fluoride. So we have to do something more, which we have now achieved. And so once again, thank you very much for the technical things, all this background information, very well presented. And this is now rounded up by the discussion. Special thanks also to Dr. Maya from Lebanon as a heavy user of that material. And this will be the next step in successful treatment of hypersensitivities and strengthening the teeth in general and doing a good job in the daily business. So thank you very much.
Thank you. Thank you.
Big round of applause for those guys. Thank you very much, for your insights. Did a great job. Thank you for coming.